Hello, everybody. This is Graham Chilius. I'm a physician from Kauai, where I've been practicing now for almost 12 years. And today I'm going to talk to you about how telehealth can provide opportunities for greater access to medication assisted treatment, especially for opioid use disorders, and specifically how this can fill holes that are currently in the system. This presentation is pre-recorded, so if you submit your questions, I'll respond real time to your questions as we go on. So the access to medication-assisted treatment for opioid use disorders and other chemical dependencies is really full of big holes. And there are a number of healthcare settings where access to MAT is limited, and telehealth can solve these problems. A common question, first of all, is it legal to prescribe a controlled substance such as buprenorphine? And yes, it is legal, although there are some specific rules to follow. And here I have the link to the DEA document that specifically addresses this. But most importantly, if you've never seen a patient in person before, the patient must be physically in a clinic or with a provider registered with the DEA. Now, prior to this whole pandemic thing, I would never have imagined prescribing, especially controlled substance, to someone I'd never seen in person until this year when actually I was in quarantine for a while. Some of my patients were in quarantine, and all of a sudden access and in-person delivery of chemical dependency treatment becomes much more difficult. So this is that document that I was talking about, and feel free to peruse it. It's pretty straightforward. And so what I've been doing is mostly telemedicine in the outpatient setting, and this is the obvious place to start. And if you are going to see a new patient that you've never seen in person before, you need to have some collaboration with a clinic or with another provider. Or if you're like me, these are your own patients who are in quarantine or stuck off island. The only, in quotes, new patient that I saw with telemedicine is patients I haven't seen for a couple of years who are back into the program. They're new to our electronic medical record, but I have an established relationship with them. Some good news for you. If you do not have your Suboxone license, otherwise known as your DEA X waiver, with grant funds through the Hawaii State Rural Health Association, you can get $1,000 as a reimbursement of your time and effort for getting your X waiver. So when you're beginning your Suboxone practice, for lack of a better term, although buprenorphine is probably preferred, you need a peer-to-peer support person. And so I have posted here my email address, and I asked a million questions, and so should you. I have made every mistake, so you don't have to. Although I'm sure you will find new problems to solve. I myself, early on in my career, back in Alaska mostly before I came to Hawaii, I put 6 different people in the ER with precipitated withdrawal, trying to figure out methadone and fentanyl patches and high-dose opioids and just all kinds of different problems I ran into. Eventually, my addiction medicine fellowship-trained medical school buddy, who I use as my peer support person, eventually told me, hey, listen, you have more experience than I do. And so, I mean, we still talk, but eventually, the student becomes the teacher. And in that vein, I have actually produced a whole bunch of videos on YouTube. It's the Dr. Graham Chilius YouTube channel. If you're new to it, watch a few of my videos, kind of get where I come from, kind of my framework for treatment, some specific information about different programs that I'm doing, different settings, outpatients, in the jail, in the hospital, etc. It turns out also, in my experience currently, there are few people who need an induction in the office anymore. So you can actually do new patients with telemedicine with somebody who's off-site. Most new patients actually have used buprenorphine in the past. There's a lot of people out there. Unfortunately, there's a lot of sharing and diversion, which is not ideal for a lot of reasons. But the majority of the people who are coming into our office already have buprenorphine in their system when we check the urine drug screen. Also, one other thing, people try to use self-service for a video like FaceTime or whatever. It is terrible. It always freezes up. It will drive you crazy. Most of the time, I've started out with like a video thing, and then it just, gets all wonky. And so many times I just call people on the phone after I've kind of like got a little face-to-face time. As mentioned before, your new patient, if you're going to see a brand new patient never seen before in person, will need to be in a DEA registered clinic or with a DEA registered provider who you're collaborating with. As far as monitoring goes, you can do this off-site. Patients can get a urine drug screen with a commercial lab, such as clinical labs or diagnostic labs. As far as pill count goes, just have them go back to the pharmacy that they picked up their Suboxone or Subutex or whatever they're using to count their pills or strips, and then follow that PDMP every visit. That is such a powerful tool. And then one thing to make that really easy is to make sure everyone that works for you is a delegate for the PDMP, and they just check into it and sign up for it. I have my staff print a PDMP report for every visit, but if you want to save some paper, just having them search it up so that when you look at your recent searches, if they're a delegate, it'll show up. And that just makes looking at the report way faster. You don't have to type in their name and birth date and all that kind of stuff. So as I move forward with these other settings, I just wanted to kind of put up this reality check here real quick. Chemical dependency is a mental health disease, and patients typically will have moments where they briefly have the motivation to seek help, and I typically call it a moment of clarity, but really it's just a moment of motivation where they're like, okay, I'm going to do this. And we need to be ready at every point of care, whether it's in the hospital, outpatient, in the jail, wherever we are, because opioid use disorder is a life-threatening illness. However, most of my patients do not just address it. Many times they're resistant to do the work that needs to be done. And of course, the healthcare system, as I'm addressing today, often pretends that it's just not that dangerous, and we don't directly address it at every opportunity. There's mixed numbers. The CDC preliminary data, they're anticipating there'll eventually be 59 opioid deaths for 2019 in Hawaii. Just to remind you, Hawaii COVID deaths 74. This is a significant problem. Let me pass by you a few cases. So June of this year, a patient is, I believe, transferred to Honolulu from Kauai, 20-year-old patient who ended up having open cardiac surgery for IV heroin-related infection. This patient reports that they asked for buprenorphine, was told by a large facility on Oahu who does, cardiac surgery, so that limits it to a few hospitals, was told no one prescribes it, and the patient was discharged back to Kauai and immediately began using IV heroin again. I like to say that chemical dependency is like diabetes of the brain. And I like to set it up like this. I like to say that adult onset diabetes nearly always is due to lifestyle choices. And, these people are not bad people. They've made some bad decisions, yet we go ahead and we treat the diabetes as inpatients when they come in for diabetes-related complications. We don't just ignore it because they did it to themselves, but somehow when people come in with a chemical dependency problem, who, again, they've made some bad choices. Yes, they did it to themselves, but for some reason, here's a person in the hospital clearly with an endocarditis due to IV heroin use, but we don't offer them medication-assisted treatment for their opioid use disorder when they're inpatient. And I can't imagine a similar scenario where somebody has osteomyelitis due to their diabetes or urosepsis or whatever, and we just don't address their diabetes at all because, whatever. Well, they're not that serious about it, or they did it to themselves, etc. So in the inpatient setting at our small hospital, KVMH, way out on the west side of Kauai, our hospitalist director, Dr. Cindy Horton, of course, in collaboration with a lot of other people, got this through PNT. Of course, we had it based on a large system, which I'll show you, the Advantage Health system. And you can watch a brief summary of the kind of the nuts and bolts of our protocol if you watch the video on my YouTube channel. This is the Advantage Health policy that we based ours on, and you can see up in the upper right-hand corner, there's Dr. Horton's looks good, Cindy Horton. So I just want to kind of reinforce this inpatient problem. Same month, June 2020, now this is on my island, patient who had been in my practice a few years ago at Wilcox Hospital for 5 days for antibiotics and an IND of an arm infection due to IV heroin use, discharged with instructions to see me to restart. The patient doesn't have a phone, and I got the discharge summary faxed over to me in the morning, and I saw it. I was like, holy smokes, I got to call this guy. I called the hospital. He had left already. Of course, he doesn't have a phone that works. So using our network of patients that we think know each other, whatever, we finally contact him, try to get him to show up. Of course, he doesn't have reliable transportation. So, what I did is I actually asked their chief medical officer, spread the word, give my cell number. They knew he was my patient. And, and so why they didn't start him on buprenorphine, because buprenorphine has been on formulary there for years. I have consulting privileges at Wilcox. I don't know. But, this is a consistent problem. And even patients who land in the ER have the same issue. So this is just a couple weeks ago. One of my patients is over on Oahu, and this is the text from the ER visit. Patient was also consulted by social work for a narcotic opioid detox patient, was requesting methadone or Suboxone, of which unfortunately we do not have the capability to initiate at this time. This was verified by the ED attending Gary, was given a referral for initiation of these medications tomorrow morning. However, unfortunately, patient left, which is typical. And so, of course, after I got this, I was a little bit upset, and I called Queens, and Queens has buprenorphine on the formulary. It's the largest hospital in Honolulu, and they actually have both buprenorphine and Suboxone in stock there. And so, of course, I talked to the pharmacist there. I discussed the 3-day rule, but, it needs to be a top-down effort to get everybody to understand that you can prescribe buprenorphine in the ER. Don't forget the 3-day rule. Any physician can administer buprenorphine with no Suboxone DEA license, just any licensed physician at all in the ER, and the patient can return every day for 3 days to get their dose. And then hopefully by that time they have an appointment with me or some other community provider. And if you're not certain about the dose, call someone. Call or just ask the patient, like, what have you been using lately? Or for that matter, look at the PDMP and see, oh, this person was taking 16 milligrams. And just make a phone call and go. There's no reason not to restart. This patient who asked for buprenorphine in the ER, clearly a great case for telemedicine, should have had a phone call to somebody and should have started on that buprenorphine. So, I wanted to recognize one of the great doctors we have on Kauai, Marty Downs, dedicated his career to reducing drowning deaths for the locals on Kauai and also the visitors. Great doctor. He calls me. He calls me up. I'm not on call. Hey, I got this person. And, we'll work it out. This is what we're talking about. If for whatever reason your facility does not have buprenorphine on formulary, get it. Every facility that I know of has buprenorphine on formulary, but maybe some of the smaller hospitals don't. ERs are easy. just get the patient on the phone, bill it. They're already in a DEA licensed center. They're in the presence of a DEA licensed provider. Telemedicine is super slick. However, you probably need to be credentialed in order to provide services within the facility. But that is certainly an easy obstacle to overcome. One of the really significant problems that we have, a major hole in our Swiss cheese here, is residential treatment programs. I don't know if you guys saw the JAMA article that came out just a couple weeks ago, finding in this large survey that only 29% of residential treatment programs offer maintenance medication-assisted treatment. They called it OAT, but it's basically the same thing as MAT for opioid use disorder. And I mean, clearly hiring a physician to come into these places to provide this would be expensive. But that's actually not the main obstacle, and I'll describe that here in a minute. But the main obstacle, according to the JAMA article, is that a lot of these programs just plain old have an anti-medication assisted treatment for OUD culture. They just simply don't believe it's the right thing to do, even though the evidence is overwhelming. And so why does this matter? Well, according to, and I didn't give all the sources here, but depending on the source that you look at, anywhere from 65 to 85% of discharged patients from a residential treatment program will relapse in the first month. And 17% of those will receive medical care for an overdose, and many will die. And according to this Journal of Substance Abuse Treatment in 2013, and there's other studies out there, this is just the one I happen to have off the top of my head, giving medication-assisted treatment for OUD reduces the risk of death by 66% after discharge from a residential treatment program. This is definitely solvable. A program just needs to register with the DEA, so they need a tax ID and $244, not insurmountable. And then, somebody just needs to call them up, or they need to call somebody up. Telehealth is the perfect solution. There's almost no cost to the program to offer evidence-based treatment. And due to the risk of fatal overdose after discharge, I believe residential programs here in the state of Hawaii that do not offer medication-assisted treatment for opioid use disorder should not be licensed, or definitely shouldn't be able to bill Medicaid. We should not be subsidizing these programs. Another hole that I think I've been working really hard to fill, and it is difficult, is jails. So it turns out that about 1 inmate in 12 with opioid use disorder will die from overdose if they haven't been given medication-assisted treatment after release. And in 2019, the First Circuit Court of Appeals, a federal court, found that not offering medication-assisted treatment for opioid use disorder for inmates violates the Eighth Amendment because it's cruel and unusual punishment, because it's like a partial death sentence, because 1 in 12 are going to die when they get released, and also violates the American with Disabilities Act. So we have been running a pilot project on Kauai at Kauai County Correctional Center, or KCCC, for the last about a year and a half. We are really trying to build a comprehensive program that basically offers the inmates a intensive outpatient program style intervention with MAT while they're in jail, offering lots of different options for MAT for them. We have identified a whole bunch of barriers that we're having mixed success in overcoming. But now that HSRHA has had this major outbreak that's really sucking all the oxygen out of the room, and that's really stalled our progress, but we're trying to push forward. As I noted before, this, in my experience, is the most difficult because you're not part of the team. You do need Department of Public Safety physician to write or approve your recommendations if you are doing telehealth. So there's that additional layer of difficulty. And overall, healthcare is not the primary concern of the system. And so for myself, frequently when I show up to see a patient, they are unexpectedly in court or released or bailed, and it gets to be really problematic. However, if you do get it to work, the impact can be huge. For those who complete 5 injections of Vivitrol after release, 0% of them are rearrested, compared to about 33% rearrest rate for those who drop out of the program. That's a huge difference. And the other thing is, we are making some progress. All Department of Public Safety physicians are supposed to get their X waiver this month. But they need a community to support them. They need the peer support. So, be ready to do telemedicine, back them up, give them some of your experience if you're already practicing. In summary here, get your X waiver, collect $1,000, immediately call any facility, a jail, a residential treatment program, a hospital, whatever. They all likely need medication-assisted treatment by telehealth support. Remember, opioid use disorder is a life-threatening illness, not a personality trait. Please submit your questions. Thanks.